So, well, one of the models so this is a Porter thing, and Harvard School of Competitiveness and Economics and Competitiveness drives this, or is the leader in this in this thinking. Suggests these centers of excellence. How feasible is this? Something that you look at? Is something so that involves a funder with the doctors group, perhaps, and with the if there's any I mean, we've got Lance, but anesthetists are a bit of a tough one. Is there any, are these arrangements common? Are they becoming more and more commonplace? I mean, if I'd say to you, what percentage of your revenue is value-based care?
Okay, yeah. So, in terms of what proportion of
cost
our
in
spend
your case, revenue in your case, sorry.
Yeah, cost in our case. So, within the Discovery Health Medical Scheme space, currently, about 50% actually of our spend within the hospital environment is within a value-based or ARM arrangement. And when I say hospital, actually, that includes a lot of the specialists, within certain governance projects. So, as I indicated earlier, we've started this journey some years back, and in the last 5 years, actually, last 4 to 5 years, we've shifted that from 33% to 50%. So it shows that we are starting to accelerate.
50%?
Hospital, but that includes specialists. We've got a number of projects, but they are at different stages of maturity. So, across different levels. So the issue is, again, I think it's a common understanding of what value-based care, means and requires. So one of the challenges is, in the concept itself, everybody kind of buys into it. But there are these constraints. So, for example, you need a robust, enabling ICT infrastructure to be able to do this. Because to speak value, you are speaking outcomes. And to speak outcomes, you need to be able to collect the data. You need to have systems that are interoperable between the players, to enable the sharing of that data, the interpretation of that data. That's all the measurement space. You need proper ICD coding systems, and then you can get to a space where you say you are able to measure the outcomes. And that's one of the biggest challenges in the environment right now. So, as I've said earlier, our projects or programs are in various stages of maturity. And that's one of the biggest challenges there is actually the measurement of clinical outcomes, number one. We've moved some way in terms of measuring patient, because we said patient is at the center of value-based care. It must be outcomes that actually matter to the patient. And within Discovery Health Medical Scheme, we started to measure patient-reported, experience and patient-reported outcomes, within some of our programs. So, but the challenge, again, as I say, is clinical. It's easier to measure process, outcomes. But that also requires a number of things to be in place, which isn't always easy. But to actually get the clinical data, from the clinicians is the difficulty. So we it's a journey, as I've indicated.
So Victoria, you guys have recently, with your other hat on, launched one of these kind of arrangements. Perhaps we could just share. Just broadly principles how it works as a practical example.
Okay. So I'm one of the co-founders of a company called Aligned, which is offering a comprehensive business solution to medical aid schemes to improve access to palliative care for their members. So the rationale really for Aligned in the first place was that there's a kind of huge lose-lose-lose going on at the moment regarding palliative care, because patients are not receiving the care that they want or deserve at the end of life. Around 70% of patients say that they would prefer to die at home, and in the medical scheme environment, that's almost reversed, and 70% of people die in hospital and often in intensive care. So patients are not having the death that they want. But the flip side, of course, for the schemes is it's also extremely expensive for people to be dying in hospital. And that's the real perversity of it, especially in a situation where you have, members only have a hospital plan, care is not covered at home, and therefore they're forced to go into a hospital to access the care that they need. But then the irony being, of course, that if they had been treated at home by doctors and nurses who are specialized in home-based care, then it would have been much, much, much cheaper for their medical scheme. And the third lose in the palliative situation is that because it's a relatively new specialty, there's not an established mode of paying for palliative care, I should say outside of Discovery's advanced illness benefit. But so if you're a palliative trained GP or a palliative trained oncologist, all you can bill is a normal GP consultation, but a palliative care consultation takes, much longer. So we started from a position of feeling that that there was a way that we could switch it to a win-win-win by increasing access. And we're doing that with a value-based contracting mechanism for multidisciplinary palliative teams. So the product that Aligned offers to medical schemes has a number of components. The first component is the benefit design. What is, how, on what criteria do patients become eligible, and when they are eligible, what are they entitled to in terms of care at home? And then there's we've put together a network of palliative doctors in association with the Palliative Practitioners Association of South Africa, PALPRAC. So we've got a network, and then we've also developed a value-based contract for the palliative practitioner. I'll just say one quick thing on that, which is because the topic is the value-based care. The structure of the contract is a global professional fee for a multidisciplinary team. So the palliative doctor, nurse, and social worker are all reimbursed on the basis of a daily fee for taking care of the patient. And they get that daily fee for every day that the patient is under their care, regardless of whether there is a visit to the patient on that particular day.
So, Shrey, now let's say they're successful at this. What happens to hospital occupancies with things like this? And how do you react as a provider, do you think, in those kind of settings?
Without sounding controversial, I think the conversation we have internally is globally, there's a reality that healthcare is becoming or is already relatively unaffordable. And you have to move to lower cost models. That's just the reality. So I think if you listen to us publicly, we don't refer to ourselves as a hospital group. We refer to ourselves as a healthcare provider. And if that needs to be provided in an out-of-hospital setting, and that's more appropriate for a patient, that's more appropriate for a patient. I think to Jasper's point, innovation is required, change in the model. This isn't about fighting for how we protect our means. This is for saying, how do we evolve the model? Because healthcare is just no longer an affordable metric.
People forget that you are the live esidimeni in providing those, when that happened, it was your hospital group that was providing those services. For instance, in a very good example of
Yeah, because I think that's a great example. I think Esidimeni is quite a sad story for me. I mean, it's tragic what happened. There's been such a focus on that event. People have lost sight of how disenfranchised that segment of society is, and that's the longest standing PPP in this country that for probably the better part of a few decades has taken care of a segment of society. And, again, people were focused on cost, and unfortunately with best intention, I think everyone's always well-intended. Certain decisions got made that hopefully, I think all of us collectively ensure don't happen again.